Guida asked me to talk about this, so I'm here to talk about this. She's seen me talk on this topic before, and some others have as well. I know, and it's difficult to talk about sudden death and epilepsy for lots of obvious reasons, but I think it's important. And so I will talk for a while, and then we can also have some questions as well. So, we know that people with epilepsy are at an increased risk of premature death compared to the general population. So a standardized mortality ratio means what is the chance that a person will die compared to the general population. So the standardized mortality ratio for people with epilepsy, all kinds of epilepsy, is 2.3. That means people with epilepsy are 2.3 times more likely to die than people without epilepsy. And that is actually higher for children. So children with epilepsy are 5 to 9 times more likely to die than children without epilepsy. And the reason for that is because of the high mortality that is among children with significant neurological impairment and the overall low mortality rates among children in general. So what I mean by that is that we know that children with multiple disabilities, particularly neurological disabilities that give them other types of challenges and handicaps, that those children have an increased risk of dying prematurely. And because those children also have epilepsy, that increases overall the death rates among children with epilepsy. This is a picture that was drawn by a girl who had epilepsy, and this half of the face is when she's having a seizure, and this half of her face is when she's not having a seizure. There's been some good work actually looking at the rates of death in people with epilepsy. This is a very big study that was done where they looked at mortality in childhood onset epilepsy. So these are not deaths that happened during childhood. These are deaths, for the most part, that happened during adulthood in people whose epilepsy started when they were a kid. So they looked at they enrolled 245 children who were diagnosed with epilepsy in 1964, and then they followed them for 40 years to see what happened to them. And they actually have lots of papers published out of this cohort looking at all sorts of different things that have happened to them. But this paper specifically looked at mortality in this group. And they found that 40 years after diagnosis, the death rate was 3 times that of the general population, and there was a 24% mortality rate. So 24% of the children who were now adults, most of them were now adults, but over the 40 years, 24% had passed away. The risk factors, meaning the factors that made it more likely that the person had died, was if they had active epilepsy. Active epilepsy means still having seizures, so as opposed to having been seizure-free for 5 years or more, and having symptomatic epilepsy. And symptomatic epilepsy refers to having epilepsy with a known underlying cause, something like Dravet Syndrome or something like a brain malformation or something that we know is causing the epilepsy, as opposed to those kinds of epilepsy that we all wish the kids would have, where in fact we can't kind of figure out what it is, but it looks like the kind where they grow out of it and then they grow out of it. Other risk factors for premature mortality in people with epilepsy include not AED adherence, so not taking your medication is a risk factor for premature death, and having drug-resistant epilepsy. But of course, we have to drill it down a bit, because when there's a person with epilepsy and they die, there's different reasons why they might die. First of all, they may die and it's completely unrelated to the epilepsy. People with epilepsy die for the same reasons that the rest of us die who don't have epilepsy. Or the death may be related to the cause of the epilepsy. Some people have a neurodegenerative disease, a disease of the brain where they're getting sicker over the time, and we know that the outcome of that disease is to die, and they also have epilepsy as part of that disease. Another example of that would be like a brain tumor, where the tumor is both causing seizures and eventually causes death. And then we have this category of deaths due to epilepsy. So in that category, I think of deaths that are a direct consequence of a seizure. So that could be you have a seizure and have a car accident because of the seizure, you have a seizure and drown because of the seizure. there are deaths due to status epilepticus. It's actually very rare for people to die as part of status epilepticus, even when it's very long, and we sometimes, not too frequently, thankfully, have children in our ICU who have status epilepticus that goes on for days and days and days, and even then it's quite rare to die. And then there's these deaths that we call sudden unexpected death in epilepsy. And I've put unexplained/unexpected because I wanted to let you know that those are essentially sudden unexplained death in epilepsy and sudden unexpected death in epilepsy are essentially the same thing. Those terms are pretty much interchangeable. They're not different conditions. We prefer the term unexpected because over time we come to understand an explanation for some of the deaths, but we still think they're part of that category. So we prefer the term sudden unexpected death in epilepsy. Before I talk more about, which is SUDEP. Before I talk more about SUDEP, though, I want to talk a little bit about what we know regarding why children with epilepsy die if they die prematurely. And this is a very large study where they actually took 4 studies that looked at mortality and pediatric epilepsy, and they put them together. So they reanalyzed the data, putting all the subjects together into one big study. So they had a lot of subjects. For pediatric epilepsy, this is like huge amount of subjects in the trial. So they had 2,239 subjects, and they were followed for a number of years, giving them 30,000 person years of epilepsy. A person year of epilepsy means that they had data on a person who lived a year. So they had the equivalent of 30,000, more than 30,000 person years. And that's quite a powerful amount of data to understand why deaths are occurring. So what they found, and this is a summary graph, one summary graph, where I've included 3 of the studies that were included in this larger cohort. What they found is that most deaths in children with epilepsy are not related to epilepsy. So you can see the red bars represent deaths that are related to epilepsy. So those could be status or SUDEP, or an accident due to a seizure. The yellow bars are a non-epilepsy related death, and you can see the yellow bars make up, like for example in this study, 80% of the deaths had nothing to do with epilepsy, and only 15% had to do with the epilepsy. Oop, pardon me. So then we can look and see, well, what is the cause of death in children when it's a non-epilepsy related death? And by far, pneumonia, which is the red bars, is by far way and above the most common cause of non-epilepsy related deaths in children with epilepsy. And when you dig down into this data, as these investigators have done, and others have done as well, this is predominantly in children who have multiple levels of disability, who get very frequent chest infections, and eventually get such a severe pneumonia that it takes their life. Okay. There are a few other causes, but by far, pneumonia is the most common. So let's look at the epilepsy-related causes of death. Again, there's one overwhelming kind of leader in this, and that is SUDEP. So whereas pneumonia is so most kids with epilepsy that die, their death is not related to their epilepsy. And when that happens, it's mainly a chest problem, pneumonia. But if they do have an epilepsy-related death, the most common cause is SUDEP. So let's talk about SUDEP. What is SUDEP? So SUDEP is as described. It's the sudden, unexpected death of a person living with epilepsy. And listed there are 8 criteria that we check off if we want to call a death. We never want to call a death anything, but if a death has occurred and we want to try and categorize it, here are the 8 criteria. The person needs to have had epilepsy, the death needs to have been unexpected, the death needs to have been sudden. It doesn't matter if their death was witnessed or not, because some SUDEP cases, there is someone there present with them, and even when that person tries to save that person, tries to resuscitate them, it's not effective. So there may be someone there, maybe there isn't someone there. It doesn't matter whether there was a seizure immediately before the death. We were just talking at the lunch about some SUDEP deaths we're aware of where family members were with the person when they died and they didn't see a seizure at the time of the death or immediately preceding the death, so we know that that can happen. And then a few other caveats. It can't be due to status, it can't be drowning or trauma. And number 8 is important because for us as researchers to actually call a death SUDEP and study it in its full entirety, we need to see that an autopsy was performed and that the autopsy doesn't demonstrate a cause of death. Because if a person with epilepsy dies unexpectedly and we don't check to see if there was some other thing going on, it's possible that there was something else going on in the body that actually led to the death. Now, that being said, because we are desperate to learn more about this, we have very valuable ways of studying deaths in people with epilepsy, even if an autopsy wasn't performed. So we're still working very actively to try and study deaths even when an autopsy wasn't performed. And we have ways that we classify those deaths so that we can still learn from them and draw conclusions. And I think that's important to families as well. I hope it is. How common is SUDEP? Well, it depends a lot on the cohort study. That means like the group of patients we study. So there's been a series of papers reporting in this group of patients, this is a SUDEP rate, and in this group of patients, this is a SUDEP rate. The important numbers to get our head around are listed there. In adults with epilepsy, the SUDEP rate is 1 in 1,000 people per year with epilepsy. So if I have 1,000 people living with epilepsy for 1 year, 1,000 adults living with epilepsy for 1 year, one of those will die of SUDEP. And then I have to take another, add one back in for the person that's passed. And then the next year, one will die of SUDEP. So 1 in 1,000 per year. In children, the rates are significantly lower, but still present. And the kind of agreed upon rate is 1 in 4,500 per year for children. Now, when you look at studies that have included people with drug-resistant epilepsy, and so some of those studies looked at people who were being evaluated for epilepsy surgery, probably drug-resistant because we don't do a lot of epilepsy surgery for people whose seizures are controlled by meds, or other groups of drug-refractory epilepsy, the rates can be quite a bit higher, up to 9 per 1,000 in people with drug-resistant epilepsy. So that's what I mean when I say it depends on the cohort you're studying. So getting to Dravet, there was, I would say some of the earliest attention paid to SUDEP in Dravet syndrome was driven by the IDEA League, right? Which is a US-based Dravet organization, a great group of people. And they had noticed that there was an increased, there was like a trend to kids, families that they followed, part of their organization, a trend to those kids dying. And so they actually put out a piece of paper and it had the data on it about their kids and all this. And I think it's really got people talking. And I just like to show that because I think that it demonstrates the power really of grassroots work and the power of families getting together and talking about their children together and realizing that that can really make a difference. Because since they started doing that, I think there's been a really impressive growth in trying to look at this problem. So they noticed 31 children dying over 10 years, and they felt that half of those were epilepsy-related deaths. So this wasn't the most scientific approach, right? But they were coming from the grassroots and they were saying, we see this in our kids, so what's going on and what are we going to do about it? So what do we really know about mortality in general in Dravet syndrome? Well, historically, the literature has been pretty limited. There was the survey of the family advocacy group. That's the formal way of saying what I just said before. There was a survey of Japanese pediatric epilepsy programs where some Japanese investigators basically sent out a survey to everybody in Japan that they knew of that were treating kids who might have Dravet, and they asked them about mortality within those programs. And there were some hospital or clinic-based cohorts where people looked at my hospital, I have this many kids with Dravet, and these are the numbers that have died. All of those really risk a referral bias. What I mean by that is that These are not general samples of Dravet. This isn't going and finding every person with Dravet that lives in the province of Ontario, whether they're treated at Sick Kids or treated by a family doctor, whether they're the member of Dravet Canada or they don't even have internet access. If you really want to do an unbiased study and figure out the mortality rates, you need to include everybody. So these are all groups where people are being seen by specialists or part of an advocacy group or something like that. So whether that changes your risk of mortality or not, that might have to do with epilepsy severity, because probably the more severe cases are more likely to be seen in, tertiary care hospitals and that. We don't know for sure, but I just have to tell you, it's not what we call population-based data. It's not like how the government gets census data where they ask everybody, right? It also means we have a bias towards pediatric deaths because aside from perhaps the wonderful care that Dr. Andrade is giving her adult patients with Dravet, there's lots of adults who have Dravet probably who are not diagnosed. And especially given the times and given that we're doing now, more Dravet diagnoses are being found now than they were 10 years ago. So because of that, there's a bias of pediatric cases in a lot of this data. And so I think it's important to point those things out. That said, I do want to share it with you so I can so that you can share in the same information that I have. And so this is a table from one of the Japanese studies. And what they found was they categorized the deaths as either a sudden death, which was a SUDEP. So those are in the kind of light colored bars. And then deaths due to acute encephalopathy, which I'm going to tell you is pretty much kind of everything else. And what they found was that the SUDEP deaths in their children with Dravet syndrome tend to happen younger. So most of their SUDEP deaths, there was a peak of SUDEP deaths under the age of 5. Here's 5. So, and then there was some consistent deaths going on up until the age of about 13, and then another little peak here in the older age. But there was an interesting finding that SUDEP seemed to be happening in children with Dravet when they were quite young. And I'll talk a little bit more about that. There's a recent study, oh, I forgot to put it on here. This is Cooper's study published in 2016. Yeah, Cooper's study published in 2016 that was an international cohort from Australia and some other countries of 100 people with Dravet, and they looked at the mortality. They found, they found a mortality rate, that's bad. It's not 1,500, it's 15.84. So there's a mortality rate of 15 per 1,000, okay? So that's all mortality, and a SUDEP rate of 9 per 1,000. So that is similar to the SUDEP rate of people with severe epilepsy, drug-resistant seizures, right? So that kind of makes sense because we know most people with Dravet have drug-resistant seizures. They also found, though, the SUDEP deaths are in the darkest color, in the black. They also found that there were SUDEP deaths. These are small numbers, right? But that so this is 2 patients, another 1 SUDEP patient, a couple SUDEP patients here, but that they do find SUDEP patients in the younger age. And this study is actually the best kind of value looking at mortality in Dravet syndrome because Shmuley, they published in 2016, they took all the previous studies, except for not the Cooper study I just referred because it came out after, but other than the Cooper study, they took all these previous studies and they put them together to try and understand more about death in Dravet syndrome. And they also found a peak of death in the younger ages, so this is 0, 5, and 10. And then the dark blue color are the SUDEP deaths. And so when that group who put all the studies together, they had 146 deaths that they looked at, or here they had 177 deaths that they looked at in Dravet syndrome. They tried to get a sense of what the cause of death was. They found 80% to be epilepsy-related deaths, and SUDEP made up 50% of the deaths, and status made up 30% of the deaths. So Dravet syndrome is looking quite different from what we know about mortality in children with epilepsy in general. Because children with epilepsy in general are more likely to have a non-epilepsy-related death, right? Most likely to be pneumonia-related. But it looks like in Dravet syndrome, children are more likely to have an epilepsy-related death, and SUDEP is among those epilepsy-related deaths. SUDEP is the most common, and status is the second most common cause. So what factors could be contributing to this increased risk of SUDEP in Dravet when we compare it to other groups of people with epilepsy? Well, let's look at what the risk factors are for SUDEP and then try and put those onto Dravet, map those onto Dravet, and see if it makes sense. So there's some very good work looking at almost 300 cases of SUDEP and comparing it to almost 1,000 cases of people living with epilepsy, and very carefully going through and seeing what's different about the people who died of SUDEP than the people who are living with their epilepsy. The most important risk factor, the most important characteristic that put people at a higher risk of SUDEP was the frequency of generalized tonic-clonic seizures. And the more generalized tonic-clonic seizures a person has, the higher their risk of SUDEP. And even having 3 a year makes a significant impact on SUDEP risk. So sadly, we know that people with Dravet often have a significant burden of convulsive, whole body shaking, generalized tonic-clonic seizures, and that is probably a significant contributor to SUDEP risk. Another important risk factor was age of epilepsy onset. The younger the age of epilepsy onset, the higher the SUDEP risk. And I've crossed out polytherapy because if you are a person who was planning on pulling this paper from the library, from the online library, and reading it, this paper does report that polytherapy, which means being treated with multiple anticonvulsants at once, this paper found it to be a SUDEP risk factor, but they were criticized for that. They went back and looked at their data. When they controlled for the number of seizures they were having, meaning when they did a further analysis, they found out that it wasn't the number of drugs people were taking, it was the number of seizures they were having. And of course, people who are having more seizures are taking more drugs, because that's why we keep prescribing the drugs, because they're having more seizures. So in fact, polytherapy or multiple medications is not a risk factor for SUDEP. And the same author, Dale Hesdorfer, had a very good look at specific drugs as well, and was not able to find any association between any one specific drug and risk of SUDEP. So there's even, I don't think I have it here, no. There's even a nice study that showed that probably adding drugs that are effective reduces SUDEP risk, which makes sense because it's mainly about the seizures. There are some other risk factors. I had a question earlier on a cue card about nocturnal seizures, and I mentioned at that time that nocturnal seizures are a risk for SUDEP. So that means having seizures at night. And that doesn't mean like people who only have seizures at night. It just means having had seizures at night. So there are some people who talk about like nocturnal epilepsy and think about that as a condition where you only have seizures at night. It doesn't matter whether you have them only at night or sometimes at night, just nighttime seizures increases risk. Having epilepsy for a longer period of time, having a learning disability, and having a young, and being in a certain age group. It looks kind of like SUDEP is more common among 20 to 40-year-olds, but not in Dravet. In Dravet, it looks like it happens during childhood. So, do Dravet characteristics increase SUDEP risk? Well, we know that the frequency of generalized tonic-clonic seizures is the most important risk factor for SUDEP. I'm a broken record on this one, and anybody who knows me has heard me say it like 1,000 times because people really need to understand that. The Japanese series found seizure severity not to be a factor in mortality in Dravet. So even though we could ascribe it to that, it's not 100% clear that that's the case. But people with Dravet do have early onset epilepsy. They do often have a comorbid cognitive impairment, right? Learning problems or thinking problems. But the early SUDEP deaths that we see in Dravet don't fit with what we know about longer epilepsy duration as a SUDEP risk factor. So there is something different about SUDEP and Dravet. The deaths happen younger, and that doesn't seem to be linked to seizure frequency in the way that it does seem to be in the typical SUDEP population, which is older kids or older people. Could it be that there's something specific about Dravet that puts people at risk for sudden death? Well, about 70 to 80% of people with Dravet have the sodium channel mutation that we've heard a fair bit about today. And so there's starting to be some work coming out looking at whether that sodium channel mutation puts people at risk for heart problems that then cause them to die. So there's a couple studies where they looked, and these actually, they contradict each other basically. One study found that there were changes in heart function related to sodium channel mutations, and one study found that there were changes the changes were not related to sodium channel mutations. So it's an attractive hypothesis. This is just a little bit of data just to tell us we don't know the answer yet. So it doesn't mean we have, the answer is no. It means we need more work on the topic. So I'm keeping an eye on time because Guida's back in here now. She's going to give me the hook soon. That's okay. So what can we do to reduce the risk of SUDEP and Dravet? Well, I don't actually for sure know the answer to that yet. And I think we need to understand Dravet-specific risk factors for SUDEP so that we can impact them. And some of those risk factors might be ones that are modifiable that we can do something about how we treat the disease, something about lifestyle factors, okay? And so we do have a Dravet SUDEP Registry where we are collecting information on people with Dravet who have died of SUDEP. And that is work that's collaboration of my pediatric SUDEP registry with the North American SUDEP Registry. And it is work that we have some funding from dravetCanada to help support. And I'm going to tell you just briefly a little bit about the cases of Dravet that we have so far in our SUDEP registry. We've had 14 cases of SUDEP and Dravet so far, and we have information on 46 controls. Actually, right now we only have 33, like good data on 33 controls. So that means we're going to be able to compare what are the people like with Dravet who died compared to people with Dravet who didn't die of SUDEP. So that's the same. We have the SUDEP cases that we have so far actually span the ages. These are under 2, 2 to 5, 6 to 10, 11 to 15, and so on. So they actually span the ages. So we don't have that lump of cases like has been seen in other studies yet. We know that for the most part, the deaths are not witnessed. Only 18% of the deaths were witnessed. 60% of the time, the people who died were found in the face-down position, which is felt to be a common finding in SUDEP. 4 of 10, so 40% were awake at the time prior to death, unlike what we hear in some SUDEP studies where most people come out of sleep. And 36%, the parents reported that they'd been recently unwell with an infection, illness, or fever. So that might also be something else that we want to try to understand. Whether a recent infection or fever causes an increase in seizures that increases SUDEP risk is one possibility. The other is that there's actually just something about the illness that is conspiring with the condition to make death more likely. Sorry. And then some of the other factors that we're looking at are things that families ask us a lot about. Is it okay for my child to sleep with a pillow? Can they sleep in their own room? Should they be, well, Guida talked about how she got a good night's sleep last night, right? Because Danielle wasn't with her, right? So should I be sleeping in the same bed as my child? Should I be sharing a room with my child? Am I using a baby monitor? So when we compare pillow use, room sharing, bed sharing, and using a video or baby monitor or auditory baby monitor between people who had died and people who were still living with SUDEP, there was no difference. Now, these are very small numbers, but at least in a preliminary way, it suggests that these things are not impacting SUDEP risk. But we need to study that more. And for that, to be honest, we need much more data. So I'm wrapping it up. What do we know about SUDEP and Dravet? First of all, we know that the premature mortality and epilepsy-related mortality in Dravet is greater than that seen in general childhood onset epilepsy. It appears that SUDEP accounts for nearly half the deaths in Dravet syndrome. This may be similar to rates of death in other cohorts of children with severe drug-resistant epilepsy, but we really need more information to figure that out. And it does look like SUDEP happens at a younger age in Dravet syndrome. We need to, we can say that the animal models support an interaction between SUDEP and Dravet, but more information is needed there as well, and it's really, more work is needed. So, as I mentioned, we're fortunate to be running this Dravet SUDEP Registry. If you would like more information about it, or you have a case of SUDEP in Dravet that you would like to report to us, or a SUDEP case in general, you can send an email and we'll help you out. You're also welcome to contact me directly. Thanks to our funders who support this work. And these are not young people who had Dravet, but these are young people who had epilepsy. And the families of these 5 people all have supported my SUDEP research in one way or another. So I think it's nice to close with their photos. Thank you.